Welcome back to NURS 238, Classification and Management of Mental Disorders. I want to continue with the anxiety disorders, but this time we are going to look at the anxiety-related disorders, and by that we mean we're looking at the somatoform disorders. So somatoform disorders are characterized by physical symptoms suggesting medical disease, but without demonstrable organic pathology or known pathophysiological mechanism to account for them. They are classified as mental disorders because pathophysiological processes are not demonstrable or understandable by existing laboratory procedure, and there is either evidence of strong presumption that psychological factors are the major cause of the symptoms. It is now well documented that a large proportion of clients in general medical outpatient clinics and private medical offices do not have organic disease requiring medical treatment. It is likely that many of these clients have somatoform disorders, but they do not perceive themselves as having a psychiatric problem and thus do not seek treatment from a psychiatrist. Let's look at the types of somatoform disorders we have. There are 5 basic types of somatoform disorders. They include somatization disorder, conversion disorder, hypochondriasis, body dysmorphic disorder, and pain disorder. So let's take them one after the other and look at what they are. Or before then, let's look at the cardinal symptoms of somatoform disorders. So they have symptoms that run through them, cardinal symptoms. By cardinal symptoms, we are saying that these symptoms run in all the somatoform disorders. So the first symptoms is physical symptoms without medical cause. Number 2, symptoms are not intentionally produced. Number 3, psychological factors are associated with the symptoms. And number 4, persistent request for medical attention. So these are the cardinal symptoms of all the somatoform disorders. All somatoform disorders are more common in women than in men, with the exception of hypochondriasis, which affects women and men equally. Somatization and conversion disorder are more common in the poorly educated, in rural areas, and in individuals from the lower socioeconomic groups. So let's start by looking at the somatoform disorders one after the other. The first one I want to look at is somatization disorder. Somatization disorder, this is characterized by multiple physical symptoms or somatic symptoms. It begins, when we say somatic, we say body symptoms, and this begins by 30 years of age, extends over several years, and includes a combination of pain and gastrointestinal, sexual, and pseudo-neurologic symptoms. The symptoms cannot be explained medically and are associated with psychosocial distress and long-term seeking of assistance from healthcare professionals. Anxiety and depression are frequently manifested, and suicidal threats and attempts are not uncommon. When suicide results, it is usually in association with substance abuse. In somatization disorder, there are 4 pain symptoms. A history of pain related to at least 4 different sites of functions, example, head, abdomen, back, joints, extremities, chest, the rectum, during menstruation, during sexual intercourse, or during urination. And there must be 2 gastrointestinal symptoms. So the patient will complain of a history of at least 2 gastrointestinal symptoms other than pain, example, nausea, bloating, vomiting, other than during pregnancy, diarrhea, or intolerance of several different foods. Then there must be 1 sexual symptom, that is a history of at least 1 sexual or reproductive symptom other than pain, example, sexual indifference, erectile dysfunction, or ejaculatory dysfunction, irregular menses, excessive menstrual bleeding, vomiting throughout pregnancy. And there's also 1 pseudo-neurological symptom, a history of at least 1 symptom of deficit suggesting a neurological condition not limited to pain, example, conversion symptoms such as impaired coordination or balance, paralysis or localized weaknesses, difficulty swallowing, or lump in the throat. There may be aphonia, urinary retention, hallucinations, loss of touch or pain sensation, double vision, blindness, deafness, seizures, dissociative symptoms such as amnesia or loss of consciousness other than fainting. The symptoms are not intentionally produced or feigned, as in factitious disorder or malingering. We'll look at factitious disorder and malingering later. But I'm saying here that in somatic disorder or somatization disorder, the symptoms are not intentionally produced. They are not feigned, as in factitious disorder or malingering disorder. So in malingering disorder and factitious disorder, the symptoms are intentionally produced. They are feigned, but it's not so in somatization disorder. The next somatoform disorder I want to look at is pain disorder. Pain disorder has the primary physical symptom of pain. So the primary physical symptom of pain disorder is pain, which generally is unrelieved by analgesics and greatly affected by psychological factors in terms of onset, severity, exacerbation, and maintenance. Characteristic behaviors include frequent visits to physicians in an effort to obtain relief, excessive use of analgesics, and requests for surgery. The pain is in one or more anatomical sites in the predominant focus of the clinical presentation and is sufficient severity to warrant clinical attention. The symptom is not intentionally produced or feigned, as in, again, factitious disorder or malingering. Pain disorder may be coded as acute, that is, duration of symptoms less than 6 months, or chronic, duration of symptoms of 6 months or longer. Associated with psychological factors, psychological factors are judged to have the major role in the onset, severity, exacerbation, or maintenance of pain. Associated with both psychological factors and a general medical condition, both psychological factors and general medical conditions are judged to have important roles in the onset, severity, exacerbation, or maintenance of pain. How do we nurse an individual suffering from pain disorder? Monitor physicians' ongoing assessment and laboratory reports to ascertain that organic pathology is clearly ruled out. Recognize and accept the pain is indeed real to the client, even though no organic etiology can be identified. Denying the client's feelings is non-therapeutic and hinders the development of trusting relationship. Observe and record the duration and intensity of the pain. Note factors that precipitate the onset of pain. Provide pain medication as prescribed by the physician. Provide nursing comfort measures. Example, a back rub, a warm bath. This may provide some relief from the pain. Offer attention at times when client is not focusing on pain. Positive reinforcement encourages repetition of adaptive behaviors. Encourage client to identify alternative methods of coping with stress. This may avert the use of pain as a maladaptive response to stress. Exploit ways to intervene as symptoms begin to intensify, so that pain does not become disabling. Example, deep breathing exercise, application of hot or cold compresses, and sometimes you do relaxation exercise. We continue with the nursing management as far as pain is concerned. Increase amount of attention given during times when client is not focusing on pain. This separates person from the behavior. The client experiences unconditional acceptance without a need for the pain behavior. Describe to the client how the focus on pain and self discourages others from wanting to spend time with him or her. Client may not realize how own behavior is perceived and may result in alienation from others. The next somatoform disorder I want to look at is conversion disorder. Conversion disorder, sometimes called conversion reaction, is a loss or a change in body functions So conversion disorder, sometimes called conversion reaction, is a loss of or change in body functions resulting from psychological conflict, the physical symptoms of which cannot be explained by a known medical disorder or pathophysiological mechanism. Clients are unaware of the psychological basis and are therefore unable to control their symptoms. Conversion symptoms affect voluntary motor or sensory functioning suggestive of neurological disease and are therefore sometimes called pseudo-neurological disorder. So conversion disorder is sometimes called pseudo-neurological disorder. The symptoms appear suddenly, and often the person expresses a relative lack of concern that is out of keeping with the severity of the impairment. This lack of concern is identified as labile indifference and is often a clue to the physician that the problem may be psychological rather than physical. The symptoms are not intentionally produced or feigned, as in, again, factitious disorder or malingering. Most conversion symptoms resolve within a few days or weeks. About 75% of people who experience conversion symptoms never experience another episode, but 25% have additional episodes during periods of stress. What are the symptoms of conversion disorder? They include paralysis, aphonia, seizures, difficulty swallowing, also called globus hystericus, urinary retention, blindness, deafness, double vision, anosmia, loss of pain sensation. There is sometimes pseudocyesis, that is poor pregnancy, is a conversion symptom and may represent a wish for or a fear of pregnancy. So if an individual suffers from conversion disorder and presents with pseudocyesis, it means that the person wishes to become pregnant or fears pregnancy. There are also symptoms of blindness, symptoms of aphonia, and paralysis, and these are associated with a good prognosis. So if the patient is suffering from blindness, aphonia, and paralysis, the prognosis is good, whereas seizures and tremors are associated with poor prognosis. There is also precipitation. Precipitation of conversion symptoms must be explained by psychological factors, and this may be evidenced by the presence of primary gain, and the conversion symptoms enable avoidance of difficult situations or unpleasant activities about which he or she is anxious. Conversion symptoms promote secondary gain as a way to obtain attention or support that might not otherwise be forthcoming. For example, a patient who has an impulse to harm his domineering mother may develop paralysis of his arms and hands. The primary gain the patient receives from his symptoms is that he is unable to carry out his impulse. He may also receive secondary gain in the form of attention, manipulation of others, freedom from responsibility, and economic compensation. So the patient may receive a primary gain or a secondary gain. How do we manage conversion disorder? Monitor physicians' ongoing assessment, laboratory reports, and other data to ensure that possibility of organic pathology is clearly ruled out. Identify primary or secondary gains that the physical symptom is providing for the client. Example, increased dependency, attention, protection from experiencing a stressful event. These are considered to be etiological factors and will be used to assist in problem resolution. Do not focus on their disability and encourage client to be as independent as possible. Intervene only when client requires assistance. Positive reinforcement would encourage continual use of maladaptive response for secondary gains such as dependency. Do not allow the client to use the disability as a manipulation tool to avoid participation in therapeutic activities. Withdraw attention if client continues to focus on physical limitation. Lack of reinforcement will help to extinguish the maladaptive response. Encourage client to verbalize fears and anxieties. Help identify physical symptoms as a coping mechanism that is used in times of extreme stress. Clients with conversion disorder are usually unaware of the psychological implications of the illness. Help client identify coping mechanisms that he or she could use when faced with stressful situations rather than retreating from reality with physical disability. Clients need assistance with problem solving at the severe level of anxiety. Assess the client's level of disability. Note areas of strength and impairment. This information will be used to plan care for the patient. Maintain non-judgmental attitude when providing assistance to the client. The physical symptom is not within the client's conscious control and is very real to him or her. In order to ensure client comfort and safety, feed client if necessary, or provide assistance with containers, positioning, and so forth. Bath client or assist with bath as required. Assist with dressing, oral hygiene, combing hair, applying makeup, etc. Provide bedpan, commode, or assistance to bathroom as required. Avoid fostering dependency by intervening when client is capable of performing independently. Allow ample time to complete these activities to the best of client's ability without assistance. Provide positive reinforcement for independent accomplishment. So this brings us to the end of conversion disorder, and you have to take these references and read for more information. Thank you.